We're going to touch on a few aspects of initial treatment options. We will get into the use of surgery and radiation in another video segment. But Eric, what are the initial therapies for early stage disease?
Well, I think right now, outside of surgery, there's not much else for early stage. You know, if you're really worried about unresectable disease in the neck or lesions that are causing pain, then yes, doing a local treatment makes sense. And whether that's radiation, sometimes even embolization, I think are good options for it. But in terms of early prophylaxis, there's nothing out there that's available.
And that includes radiation therapy?
That includes radiation. So, you know, while there are older literature suggesting that patients who present with bulky disease after they have resection that they should get radiation. But there really is a lack of data showing there's really any benefit for doing it, and there are very long-term sequelae of radiation, especially in a population that can live very long, even with metastatic disease. So right now, we don't do radiation.
You know, I think it's an important point to really talk about, because the temptation to do radiation is so strong. I'm a head and neck medical oncologist. I work with head and neck surgeons, endocrine surgeons, general surgeons, and then head and neck radiation oncologists. And we're so used to treating patients with squamous cell carcinoma of the head and neck. They have surgery, they have high-risk features afterwards, positive margins or extracapsular nodal involvement, and those patients we know will benefit from external beam radiotherapy. So the whole team is geared up to treat these patients with medullary thyroid carcinoma with radiation, and you're chomping at the bit to do everything possible to cure their disease. And I think that it is important to step back and think about the relative risk and benefit. And unfortunately, we just don't have great data. It's such a rare disease. We'll certainly never have randomized studies on this question or not. But these are patients who may live for a very long time and may not have disease recurrence in the neck, even when they do have multiple nodes involved or extranodal involvement, or even positive surgical margins. They may not necessarily recur in the neck.
And why subject them to that toxicity when that's not necessary?
Right.
Steve, talk to us a little bit about monitoring for recurrent metastatic disease.
So just as in the initial evaluation, the role of calcitonin and CEA helps to dictate the staging approach, we depend very much on the biomarkers in the follow-up. Usually the way we approach is it takes some time after initial thyroidectomy for these markers to reach a nadir. So we don't measure them 1 week post-op. It may be 4 to 6 months post-op that we get really that first accurate assessment of the markers. And then we may monitor and repeat those about every 6 months initially after surgery. And the absolute height of the calcitonin in particular, again, correlates with the value of additional imaging. So if you don't know of distant metastatic disease that needs to be followed, if the calcitonin post-op is less than a couple of hundred, there's really no yield to looking for it. Ultrasound of the neck remains the critical imaging procedure. But as the calcitonin goes higher, or if, as you follow over time, and you get serial measurements of calcitonin and CEA, you can calculate the doubling time for the markers. If the doubling time is greater than 2 years, then the likelihood of significant progressive and fatal disease is quite low, and one can take an indolent approach to imaging. If the doubling times calculate out to less than 6 months, you probably do need to be more aggressively imaging regardless of the absolute height of the markers, because there's likely disease that's growing that could put the patient at peril.
We've talked